A screening recommendation for someone without symptoms cannot answer what to do with one changing or suspicious lesion. Welcome to this explainer. Today, we're diving into one of the absolute highest stakes challenges we face in clinical practice, the diagnostic workup of suspected skin cancer. Whether you're a dermatologist, a primary care clinician, or an advanced practice provider, you know that separating harmless variations from dangerous malignancies is a daily, sometimes hourly task. So let's build a really clear, evidence-based, layered workflow so we can make these critical decisions confidently and, most importantly, safely.
You might have noticed I opened with that exact thought, and, well, that's because it perfectly frames the core problem we're solving today. A screening recommendation for someone without symptoms cannot answer what to do with one changing or suspicious lesion. Too often, we see broad population health guidelines getting misapplied to the individual patient sitting right there on your exam table. We really need to distinctly separate the task of generalized population screening from the targeted, urgent evaluation of a specific, changing spot.
And to make sure we're operating with the absolute highest standard of clinical rigor, this explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. Having that level of expertise ensures every boundary and guideline we're going to discuss is grounded in deep, practical, and highly specialized evidence.
Okay, let's dive into this clinical roadmap. We'll start by looking at screening versus individual diagnosis. Then we'll move beyond the ABCDE checklist. From there, we'll build a layered detective workflow, define our dermoscopy and technology boundaries, tackle the monitor or biopsy decision, and finally wrap up with a practical biopsy decision framework.
Let's start right off with Section 1, Screening versus Individual Diagnosis. Diagnosing a specific spot is just a completely different job than screening populations.
Back in 2023, the U.S. Preventative Services Task Force stated there's insufficient evidence to balance the benefits and harms of visual skin cancer screening in asymptomatic adults without a history of malignant lesions. But, here is exactly where errors happen. That statement applies to population screening, but it gets wildly overextended. It never ever excuses ignoring a changing, bleeding, or growing lesion. Plus, it doesn't erase the need for individualized, risk-stratified surveillance for your patients who already have prior skin cancers, strong family histories, or immunosuppression. Basically, individual diagnosis means matching your intervention to the specific, actual clinical question sitting right in front of you.
Moving right along to Section 2, Beyond the ABCD checklist. Visual tools are great starting points, but they definitely aren't diagnostic absolutes.
So the crucial point is that criteria like the ABCDE checklist, the ugly duckling sign, and those classic clues for basal and squamous cell carcinomas, the pearly borders, the recurrent bleeding, the pain, these are merely attention tools. They organize our focus and they start a clinical conversation. The danger, though, the real danger, is letting an incomplete checklist overrule meaningful clinical change. They simply do not reliably rule cancer in or out on their own.
We really have to respect the dangerous blind spots of the ABCDE method. Think about it. A rapidly growing nodular melanoma, it might be perfectly symmetric, totally uniform in color and tiny. An amelanotic melanoma often presents as a deceptive, harmless-looking pink or skin-colored bump. And acral nor nail melanomas, they often just look like simple changing patches or bands, particularly in patients with darker skin tones. And while absolute incidence might be lower there, delayed recognition is tragically common. Listen, if a lesion is rapidly growing, symptomatic, or clinically discordant, it warrants evaluation, period, regardless of whether it neatly fits a catchy mnemonic.
This brings us to Section 3, the layered detective workflow. This is really the core thesis of this entire explainer. Diagnosis is a layered, progressive gathering of clues.
Let's move to and see how this builds. A truly defensible diagnostic pathway is intentionally redundant. First, you assess the patient's risk context. Then, you get the history of the lesion and compare it to their background skin. Next up is palpation, and wow, this is vital. Palpation reveals firmness, fixation, and depth. Things a flat photograph simply cannot capture. From there, you incorporate trained dermoscopy. And finally, you arrive at a calibrated threshold decision. It's like a safety net. When one input is weak, say a really blurry patient photo, the other inputs step up to cover the blind spots.
Now let's jump into Section 4, Dermoscopy and Technology Boundaries. We've got incredible technological adjuncts today, but we absolutely must set clear boundaries on what they can and cannot do. And this brilliantly illustrates the real value of proper training. Look at this. In the Cochrane Melanoma Review, at a fixed specificity of 80%,
estimated sensitivity jumped from about 76% with just a naked eye examination, all the way to 92% with trained dermoscopy. That's a huge leap. But don't miss the key word there, trained. Dermoscopy isn't just some magic magnifying glass that points out cancer. It's a learned diagnostic language of networks, streaks, and vascular architecture that you have to interpret in the context of the patient's unique history. But on the complete opposite end of the technology spectrum, we have this massive, honestly terrifying variance, 7% to 73%. That is the wild sensitivity range of consumer smartphone triage apps found in published studies. I mean, in these data sets, up to 93% of melanomas were misclassified as low risk. Talk about a hard safety boundary. A consumer app simply cannot safely clear a concerning lesion, and it for sure cannot replace the nuanced, layered assessment of a trained clinician.
Next up is Section 5, the monitor or biopsy decision. This is the critical boundary between safe observation and needing definitive tissue sampling. It is so vital to understand this next point. Monitoring is a deliberate, active clinical intervention. It is never just indecision. Safe monitoring is strictly restricted to carefully selected, mildly atypical, flat lesions that don't have any high concern features. To do it right, you need a reproducible baseline image, a strictly defined interval, a specific change threshold, and a patient you know is reliable for follow-up. It is absolutely never appropriate to just monitor a nodular, rapidly enlarging, or symptomatic lesion. In those cases, delay is downright dangerous.
Now, what's really interesting about this slide is this stark figure, 42.9%. In a meta-analysis of melanomas diagnosed by shave biopsy, the deep margin was positive in nearly 43% of cases. What's more, additional excisions ended up changing the T-stage in roughly 8% of those cases. Now, the teaching point here isn't that shave biopsies are universally bad. Not at all. It's that you have to match your biopsy technique to the staging question. If you suspect melanoma, you must get enough depth to preserve that vital staging information and avoid preventable uncertainty.
Let's bring this all together in our final section, Section 6, Practical Biopsy Decision Framework. We're going to give you a concrete tool for your daily practice.
This matrix right here summarizes everything we've talked about perfectly. Basically, your immediate clinical action is dictated by history, pattern, dermoscopy, and the pathology question. So you can confidently reassure your patient when there's long-term stability and classic benign dermoscopy. You use defined monitoring when the lesion is flat, low concern, and you know it's safe to wait to resolve any uncertainty. But, and this is key, you must move immediately to tissue diagnosis if there's meaningful evolution, an ugly duckling or nodular pattern, high concern structures, or when depth and invasion simply must be established right now to guide their treatment.
Ultimately, that is the tightrope we walk every single day in the clinic. Will you minimize consequential delay for your patients without turning every harmless variation into an unnecessary procedure? It's a tough balance. But by utilizing this layered detective workflow, combining history, palpation, trained dermoscopy, and deliberate tissue sampling, you really can protect both your patient's health and their peace of mind. Thank you so much for joining me for this explainer. Keep trusting the evidence, and I'll see you next time.